And you're live.
Good afternoon, and welcome to this year's BC Schizophrenia Society annual general meeting educational session, Schizophrenia in the Time of COVID-19. My name is Jeff Bagshaw. I'm a member of the BCSS Foundation, and I'll be your MC for the day. When we started this year, we couldn't believe things are the way they are with COVID-19, and we've just been impacted in so many different ways, some of which we may not even be aware of yet. Today, I have the very great pleasure of introducing Dr. Diane McIntosh and Dr. Randall White, two members of the BCSS Medical Advisory Committee, who will speak on how the COVID-19 pandemic has affected families and families affected by schizophrenia. Dr. McIntosh and Dr. White will both speak for about half an hour. At the end of each talk, we'll have a few minutes for questions. So if you have questions, type it in the Q&A chat online there, and we will ask them their questions. If you have any difficulty, just hit the support question, and then they'll help you out. I'd like to thank again the sponsorship, Otsuka-Lundbeck Alliance, for making this possible and allowing this to proceed with no donor dollars used at all. So I'll introduce Dr. McIntosh first. Dr. McIntosh is a clinical assistant professor at the University of British Columbia and also has a community psychiatry practice. She is extensively involved in providing continuing medical education programs to colleagues nationally and internationally with a focus on rational psychopharmacology, neurobiology of mood and anxiety disorders, as well as ADHD. Dr. McIntosh recently accepted the position of Chief Neuroscience Officer at TELUS and is responsible for optimizing all their mental health related products, services, and innovations. Since March, Dr. McIntosh has also been regularly offering tips and strategies, helping people manage with COVID-19 pandemic. Dr. McIntosh.
Screen. Let me see how that works. Share screen. Here we go. I'm going to share myself, I guess. Share. And then I'm going to go like this and like this. And Jeff, please let me know if I'm not where I think I am, which is in front of you with a big screen. So lovely to be here. Sorry, it was a little bit of well, this has been an annus horribilis for many of us. We had the pandemic, and I know that it's been some great challenges to overcome through this year, and particularly for individuals who are struggling with a mental illness, who already are somewhat vulnerable, and then on top of that, some of the big challenges that we're all facing. So when I was asked by Jean to do this talk, I wanted it to be a little more general, just talking about how we as Canadians, and especially those who are struggling with mental health, may be impacted, and some very simple tools that we can think about to help us to go through this time, perhaps with more wellness and a sense of calm and control. So I'm just going to talk a little bit about the health landscape, and while I would have loved to have been able to say pre and post-COVID, we are still mid-COVID and unfortunately on something of an upswing. Talking a little bit about the impact of mental health on people who are employed. And then actually, we're not going to talk about working with ADHD. Unfortunately, I forgot to take that one out. So let's talk a little bit about mental health care in the pre-COVID period in Canada. So most of you are aware that mental illness affects all of us. About 1 in 5 Canadians at some time will personally have a mental illness. And really what that means is that every single Canadian either has a mental illness themselves or loves someone who is living with a mental illness, working closely with someone who has a mental illness. So the reality is this affects every one of us, and we all need to pay attention and really try to battle some of the challenges that people who are currently living with a mental illness are struggling with. Now, I don't need to tell anyone who's listening that we have a real challenge with accessing psychiatry. And I do a lot of education. So the 2 surveys that I did are from 2 of the programs that I have. One is Psyched Up CME, which is, I just did one yesterday, all about neurobiology, but mostly it's focused on psychopharmacology. And I also have a website called Psyched Up that all started from helping people to use antipsychotics appropriately and switch between them. So I did a survey of about 1,500 people, a little under that, to ask family doctors, how confident are you in managing mental illness in your practice, and what's it like to try to access psychiatrists. So I'm not going to give you all the data, but I'll let you know that not surprisingly, 87% said they do not have adequate access to psychiatrists, which is negatively impacting their patient care, that they don't have the guidance that they need. 56% said they don't have adequate access, meaning it takes way too long, and 75% said the wait is somewhere between 6 and 24 months. Now, those surveys are from individuals across Canada in all kinds of different areas, from small towns to big cities. But we do have some statistics from a couple of big cities. One is in Vancouver, and many of you may remember this. It was a few years ago in 2011, where a group of individuals attempted to call every community psychiatrist in Vancouver, and they got in touch with 230, and only 6 agreed to see a patient within the next 2 months. And the comments in the paper, if you get a chance to read it, were that even then there were significant hurdles to get past to get in the door for the 6 that said that they would accept patients. I would say that stats in Toronto are maybe even a little worse. 50% of psychiatrists working full-time in Toronto see fewer than 100 patients a year, and 10% only see 40 patients a year. So those would be probably your Freudian analysts that have a very small number that they see every day. But our dollars are going to support these psychiatrists to see a very, very small number of individuals. The sobering statistic of 40% of patients who attempt suicide saw a psychiatrist within 6 months of their ER visit, and that means that 60% did not see a psychiatrist within 6 months of going to the ER with an attempt at suicide. 50% of Canadian psychiatrists are near retirement age, and the backfill is very poor. So we had a problem in psychiatry, which you all know. We also have a problem in the Canadian economy with the fact that we don't have adequate care for our patients. So 500,000 Canadians are unable to work each week due to their mental health. 30 to 40% of all short-term disability claims are related to mental health, and 30% of long-term disability. This is costing $51 billion a year, and the expectation is that by 2041, it will be $2.5 trillion. That is a cost to the Canadian economy due to mental illness. The fact that people are not able to fully work, that maybe they're absent fully, and also presenteeism. You're there, but your brain is not. You're not working up to your optimal level, which is actually more costly, believe it or not, than absenteeism on world economies. What was also really interesting, this comes from the Morneau-Chappelle data that was earlier this year, actually. 60% of employees say they would actually take less money, they would accept a job that paid them less if their prospective employer offered better wellness benefits. 77% of workers said they would consider changing their job to an employer who offers better support for mental health and well-being. And that's one of the reasons that I'm in the job that I'm in right now, is trying to improve mental health care within this organization, also for all our customers. But when I accepted the job in January, I told Darren I would only accept the job if it meant that we were going to work to improve the mental health care of all Canadians, which is 100% endorsed within this organization. So I just want to take a moment to reflect on the definition of mental health, and I think this is a very good one. It's from the World Health Organization. I believe it was 2005, and the WHO defined mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to his and her community. So I just think that's very important to point out that work productively is right in there in the definition of mental health. Now, economists, and I've read a number of different papers about this because I've given a number of talks on this topic. Really, when they're talking about mental health, they actually tend to focus on things that most people think about, like happiness and well-being scores, satisfaction with life, positive emotions, the perception of living in a meaningful way or in a productive way, giving back. The medical field has tended to focus on, you don't have symptoms. You're mentally healthy if you don't have symptoms. And of course, we use the DSM. But we know that the two are linked, right? That if you don't have good mental health, then you don't have positive emotions, you don't feel productive, you don't feel that you have meaning in your life and that what you're doing is meaningful. So I feel that the field of psychiatry really is changing, but the frustration for me is all of the talks I give where I'm asked to talk about making the patient, the individual I'm treating, the center of all care decisions. And I'm thinking, well, shouldn't we have figured this out a long time ago? I'm kind of tired of talking about this. This should be the way that we do things. Now, there is absolutely no doubt that the economy and health, mental and physical health, is inextricably linked. So we know individuals that are of low income are up to 3 times more likely to suffer from a mental illness than a wealthy person. Job loss and income decline often precedes mental illness. And we have, unfortunately, data associating recession, economic turmoil within a country, and worsening mental health outcomes, more mental illness, greater substance abuse, and higher rates of suicide. And I just want to point out that the CDC, the Center for Disease Control, and we've all heard this a lot over the last 6 months or 8 months, they came out with suicide data in the last year showing that there was a massive increase in completed suicides amongst youth aged 10 to 24, that over the last 10 years, that has increased 56%. That is unheard of. And there's lots of different reasons, but they don't know for sure why. They have more guns in the US, certainly, but we have a lot of addiction issues and a fentanyl crisis, which they have an opioid crisis down there as well. But there's something else going on, and they were in a rich economy. So my concern is what will happen now? And our data on suicide is also very troubling. So the point of talking about our economy and the impact of work is that work is very good for you. That most individuals who have a mental illness, as most of you will know, even if it's a very severe mental illness, wish to engage in meaningful work. So despite the fact that some people in our society don't seem to understand the fact that people who are mentally ill aren't lazy and don't wish to engage in work, the reality is that most people, no matter how ill they are, wish to get back to work, and want to be gainfully employed and contribute to their society. And to the point of the WHO definition, this is the essence of mental health, or one of the critical factors in mental health. Paid employment, of course, offers financial security. It gives you a structure every day, a sense of worth, and regular supportive social engagement, which is quite powerful. And of course, missing right now for so many people who are working at home. Many studies have found work is associated with better mental well-being, lower prevalence of depression, and lower prevalence or incidence of suicide. Now, there is a value to paid employment, but many of my patients are not able to be gainfully employed, partly because they will lose their benefits if they are. So we are in a situation now where so many people who wish to be gainfully employed do not feel able to do so because of the loss of benefits that they will experience. There are some people that are able to work to a certain extent, but there is a value to volunteerism as well. So I know that I'm focused on the slide and paid employment, but I do believe that there's a huge value to volunteerism as well. Now, we are at a really difficult time right now with the COVID crisis. And the first time when I created this slide was actually in April or May, I believe. Well, it was talking about the fact that the stress that we were under as a community, as a society, really is the worst kind of stress. We know that stress is bad for our brain, especially if it is chronic and unpredictable. Acute stress can actually be quite valuable. It allows us to deal with situations quickly, to adapt, and also to learn. But chronic and unpredictable stress is actually a model that is used when we're studying different kinds of therapy, different kinds of treatment. It is a paradigm for depression. And that's really what we're living in right now. So we know that chronic unpredictable stress is associated with depression, with anxiety, with cognitive impairment, with all inflammatory illnesses. And for me, this includes obesity, diabetes, heart disease, Alzheimer's disease, structural and functional brain changes in our glial cells and neurons. And that's why it's very important, the impact on all inflammatory illnesses, Alzheimer's disease, because if your glial cells, which are those supportive brain cells, do not work properly, it increases our risk of dementia and many inflammatory illnesses. So what we're living in right now is what I call this COVID-19 mental health trifecta. We're all worried about our health or the health of the ones that we love. And so many people that I know are sort of jammed between, I got these kids at home and I can't take care of them because I'm supposed to be working full time. And I've also got an elderly parent in a senior's home or quite isolated. I'm worried about them. So they have health anxiety for themselves, for their kids, and for the people they love, and also for their whole community. Then we have the financial stress. So many people have lost their jobs. People have also maybe coming towards retirement and worried about their RSPs. And we're also worried about our own economy nationally and the international economy. And then we've got the impact of isolation. And we have very good data showing that loneliness and isolation has not just an impact on your mental health, but physical health. And I read a paper just last week talking about how the impact of loneliness and isolation has a similar impact on our overall health as smoking, inactivity, and obesity. So when we were at the height of this and we're moving back into another peak of COVID, we will have a resurgence of anxiety, of this financial stress, which everyone's worried about shutdown, as well as the fear of isolation. So we saw the impact early on with this COVID pandemic that Canadians were struggling with their mental health. There was a quadrupling of not just general anxiety, but high anxiety across Canada. There was there was a doubling of the level of depression across country. Of course, there were differing from place to place, but in general, it was about double of the usual rates of depression. There was about a 30% increase in the consumption of alcohol, as well as an increase in the amount of cannabis that was being used. And about close to 60% of recently unemployed Canadians, and this was from back in May, reported their mental health had a negative impact, was negatively impacted by their job loss, which isn't surprising. Now, my view of mental health is as a spectrum. Everything is a spectrum. Everything has shades of gray. And what I'm really focused on is wherever you are in the spectrum, I want to meet you where you are and then try to push back towards the left. I want to help and try to intervene before we get into the crisis mode, but there's a way to intervene at every place along this spectrum to help people feel healthy and be healthy physically and mentally. And I want to make that point here by showing ways that you could intervene even with a healthy individual. So if someone is otherwise doing well and we want to keep them well, we want to make sure that they keep exercising, that they're maybe improving their gut biome, which is a very, very exciting area of psychiatry, by having a healthy diet and choosing Mediterranean foods, even learning how to cook healthily and shop healthily, even if you don't have a whole lot of money. Mindfulness, meditation, all of these things are valuable for a healthy individual and help to prevent them from ending up in the stressed or functionally impaired. And certainly you don't want to end up in the crisis mode. So there are ways for us to intervene at every spot. And that's why I want to focus just at the end about how we can help people that may already be healthy or in any other part of this zone, how we can help to move them towards the left, towards the less functionally impaired, less stressed, and more healthy mode. And these are some very basic things to think about, but sometimes we don't think about them when we're feeling a little scrambled by everything that's going on. Most importantly, we all thrive on a schedule. And so what happened to many of us when COVID hit and everyone went home and they were working from home is that they spent most of the day in their pajamas and people were binge on Netflix, and they lost their normal wake and sleep patterns, which are really essential to well-being. So if you end up that you're able to go back to work, being able to have a regular schedule actually helps you to transition to work life. And anyone whose kid has gone back to school after the summer knows how hard it is if you don't have a schedule to get back to school. This includes all kinds of different things. What time you get up, what time you go to bed, making sure that if you're at home that you start and stop work at a regular time so it doesn't leak into the rest of your life, your family time, making sure you schedule time for fitness, for meals, and for fun. This is an essential time for adherence to treatment, especially if you're stuck at home. You don't have the normal outlets that you would usually have, and so mood, irritability, frustration, tolerance is really at the edge. If you take medication regularly, and it doesn't matter what kind of psychiatric medication it is, you're more likely to reduce side effects. And I often hear this with ADHD. People will say, well, I take a holiday on the weekend from my ADHD medications, which is not a good idea, because people, when they're driving, need their ADHD medications when they're out with their friends, and they could be taking risks. And what happens is every time you stop and start, you're going to have more side effects. This is a place where LAIs are so valuable, and unfortunately, I think physicians are not the champions of long-acting injectable antipsychotics that they should be. We have some great ones, new ones, atypical ones that have less of the burden of some of the older ones, and they help with adherence. And I've kept more people out of the hospital because they've been on a long-acting injectable than any other drug. Avoiding avoidance, and that means that if you're worried about something, a lot of people, their first thing to do is to avoid it. And that's especially true with finances. I'm not opening those checks. Those bills. I'm not going online to see where things are. And so if you have a loved one that you're worried about and you know they're avoidant, maybe helping them to go ahead and look at those things and make a plan, because that avoidance can make things certainly far worse if we let it go too long. The importance of trying to separate work and home life, trying to make sure that, a lot of people were working in their bed, in the same place where everyone else was, and you can't close the door at night. You go from your bed to your bed. So trying to make sure that you separate off what you're doing at home, at work-wise, from the rest of your home life. That's not possible for everyone. Going outside, there's actually data that hugging a tree, that being on the grass and moving around in green space actually does have an impact on health and well-being. Cannabis and alcohol, I'd love to talk to you all day about the impact of cannabis on psychosis, the risks associated with that, and particularly in the developing brain. But I also want to bring in the importance of alcohol, and because of the fact that there was data showing we were drinking much more than usual, nothing gets you to sleep quite like alcohol, and nothing messes with your sleep quite like alcohol. So if people are struggling with their sleep, trying to limit the amount of alcohol can make a big difference. And of course, when you're at home all the time, you don't have your usual outlets, it can be somewhat easier to go there. And trying to find positivity in this challenging time. I believe that gratitude is a gift I give myself every day and helps to keep me sane, but also recognizing that our anxiety is contagious to others, and especially to our children. So I'm going to leave you with this last little bit, which is controlling what we control. I have learned in my life, and it took way too long to learn, that the only human being on earth I can control is me. I can't control my husband, my kids, my patients, no one else, only me. And so this is why this time is so stressful, is because people feel completely out of control. We didn't have all the science. The science that we had at the beginning was mostly not right. And so we have these big black holes without information, and this is why conspiracy theories have ended up in there, and this has really heightened people's anxiety. So reminding people to get their information from reputable sites, to do the basic things that we know work to keep us safe: washing our hands, wearing gloves, keeping social distance, and trying to be around friends when we're outside. Trying to keep people, if we're inside with people, that we keep them at a distance. We know those things significantly, massively decrease the risk of COVID and will allow us to get on with our lives. And the last positive thing that I want to say here is, I am a glass half full kind of person. I'm always trying to see the positives here. And I think this is really an opportunity to talk to the people we love, teach young people particularly how to critically think, how to look at the news that they're absorbing, whether it's through Twitter or Instagram or whatever, and really critically appraise that, and help them to understand how you look to make sure that what the information you're reading is actually true and accurate. So I'm going to leave you with that, and I'm going to stop sharing here, and I would be happy to answer any questions that you have. And if not, then I do have another meeting, unfortunately, that I have to run to. I hope I'm still here. There I am. Hi, Jeff. So does anyone have any questions for me?
Thanks, Dr. McIntosh. That was fantastic. We'll just wait, see what questions come up. And if you have questions, type them in the Q&A box.
I would say, Jeff, I was a little bit all over the place with that, just wanting to give a little taster menu of a kind of different thing. So certainly I wouldn't expect that people would have a whole lot of questions, but I'm happy to share my slides. Jean asked a question, how can Canada get more psychiatrists that work with people who have a severe mental illness? I'm actually working on a program right now. I am on the final steps of this journey to be able to set up a immediate access for family practitioners, for prescribers who can have immediate access to psychiatry, because that was really the reason that I wanted to connect with a company like TELUS, which has so much reach, is to create a program where we could give immediate access to psychiatric guidance. The program is called RAPIDS, and I'm in the final stages of being able to get this made. We got the whole process going, we got all the approvals, and so I'm hoping to have a what's called an MVP. I'm learning all about the business world here, a minimally viable product in the next couple of months. And I believe that this is really going to change the world of psychiatry, and it will include all psychiatric treatment, not just psychopharmacology, but that's really where family doctors need a lot of help, is with feeling confident and rational in their prescribing, but offering guidance both to the prescriber, but also to be able to share that guidance with patients as well. What is the current wait time for a psychiatrist in BC? I don't know. I know that I can't get anyone to see any patients that I try to refer. So I really struggle to find anyone who's actually taking patients. And I have had big challenges even trying to refer to the hospitals. But I maybe, Randall, I don't know, Jeff, if you've had any access to any kind of those statistics, but I know it takes far too long. And when I cut back on my practice, I tried to refer patients, and I literally could find no one to take anyone.
Okay, I think we'll move on to our second presenter. Thank you so much, Dr. McIntosh, and have fun at your next meeting.
Thanks, Jeff. Bye.
Okay, I'll introduce Dr. Randall White. Dr. Randall White is a medical director of Vancouver Community Mental Health Services for Vancouver Coastal, and the clinical director of the British Columbia Psychosis Program at UBC Hospital. He's practiced psychiatry in Canada and the United States, and currently the president of the Western Canadian branch of the American Psychiatric Association. His clinical and research interest is in understanding severe psychotic disorders, and as a clinical professor of psychiatry, he's involved in many educational activities at UBC. He's also the co-chair of the very good annual Pacific Psychopharmacology Conference and has educated the general public about mental illness at many events and in the media. Dr. White.
This is Dr. Randall White. I appreciate being invited to the BC Schizophrenia Society, AGM, to talk about COVID-19 impacts in people living with schizophrenia and psychosis. So one of the issues that people, all of us face, but it may have a particular impact on people living with chronic mental illness, is the fact that isolation and social distancing are hard. We're hearing about pandemic fatigue now. People who have chronic mental illness already have reduced social connections and smaller social networks. So necessarily having to self-isolate, having to keep social distance will have even a greater impact on them. And some of the services that they rely upon have had reduced accessibility, such as clubhouses and other community-based organizations where if people are indoors, the amount of space available is reduced in order that everybody can keep a certain distance apart. Transit services have been reduced, and a lot of people with mental illness don't own their own automobiles, and they rely on transit. And so some of the transit service they were used to may be less available. Some bus routes have been cut, for instance. And we know also that while a lot of us have been relying on internet and we're living our professional or even personal lives on Zoom and FaceTime, people with chronic mental illness and people with low incomes are less likely to have reliable access to high-speed internet and to have their own mobile phones. So they won't be able to compensate as easily as the rest of us can using technology. Now, the other challenges that people may face when it comes to preventive measures to avoid getting COVID-19 has to do with complying with public health recommendations beyond just social distancing. That could be hard enough. And as I said, the social isolation of social distancing makes it tough to follow. But if some people with mental illness, especially if they are acutely psychotic, are unable to understand the requirements, or maybe just because of their behavior, their agitation, their paranoia, they can't actually follow the guidelines, so they'll be at higher risk, possibly for exposure. They may not be able to wash their hands. Some people don't even have reliable access to water on an ongoing basis and soap. We know that some of the lower income housing facilities, or SROs, have shared bathrooms, for instance. Then there's masks. A lot of us find masks uncomfortable as it is. Wearing masks also reduces our ability to respond to each other emotionally to some extent. We aren't going to perceive smiles as easily. So mask adherence and just being around others with masks may be more challenging for people who have mental illness. If some people have a tendency to believe some of the theories that are on the internet, some of the outright conspiracies that circulate, and we know that people with psychosis are more vulnerable to these fringe ideas, then they may have less of a sense of risk, of personal infection, etc. And then there's the issue of vaccines and access to primary care. There are the conspiracies about vaccines, but furthermore, just on a much more practical level, people with chronic mental illness have, in general, less access to primary care because a lot of standard family practices aren't set up for people who need lower barriers to care, who have more trouble keeping regular appointments, who prefer a walk-in basis, etc. Now, another aspect of this has more to do with the effect of coronavirus on the brain and on the risks for mental illness and psychosis. Could coronaviruses, for instance, cause psychosis? One thing we do know is that people who are acutely ill with an infection, pneumonia, whatever, can get confused, can get delirious. But there was this study that looked really at whether coronaviruses could perhaps somehow contribute even to schizophrenia. It was kind of interesting that this was a 2011 study done in the US, and they looked at, it was a kind of a case control study. They looked at 106 people who did have a diagnosis of some kind of psychosis and 196 who had no such diagnosis. And they looked for antibodies suggesting previous coronavirus infection. Now, in 2011, the novel coronavirus did not exist. So let me be clear. Other coronaviruses that cause human disease, like SARS, MERS, and there are others too that just cause sore throats and colds. Those would have been circulating at the time. And they found that there were 4 kinds of coronavirus, not COVID-19, that were more common, or the antibodies anyway, were more common in people who had a diagnosis of psychosis compared to controls who had no such diagnosis. This is, associative. It does not prove causation, and it may not have anything to do with COVID-19 really, but we don't know what the long-term impacts of COVID-19 will be. And this study suggests that there is some possibility that it could set some people up to develop a chronic psychosis in the future. But obviously we need to do ongoing research to see if this is borne out. Now, as far as complications from COVID-19 that could have impacts on people with mental illness or could generate other mental illnesses or complications, these are some of the things that doctors are concerned about. So people who get COVID-19, even without requiring, intensive care or hospital treatment, will have some symptoms like insomnia, anxiety, depression, and fatigue. Those are being documented in a lot of patients. And then you might hear about these people with longer term effects. They call them long haulers sometimes. And it seems like in those cases, fatigue is common and maybe some mood symptoms. People who smoke, and a lot of our clients with schizophrenia and mental illness do smoke, are going to have higher likelihood of developing, pulmonary complications and pneumonia. Also, antipsychotics, especially a couple of them like Clozapine, seem to elevate the risk, not hugely, but do elevate the risk, maybe double it for pneumonia. With Clozapine, this is an antipsychotic that can cause excess salivation, and that may play a role. Now, I mentioned something about delirium. So delirium is a state of confusion. Some people call it acute brain failure. So critically ill people who have widespread infection, trauma, in intensive cares, they often develop this kind of confusional state, and it can involve hallucinations. It can involve agitated behaviors. 30% of people in ICU with COVID-19 may develop that. Then there are medications. So steroids are now being used for critically ill people, and steroids can cause mood changes. They can even cause hallucinations or psychosis. COVID-19 rarely can directly attack the central nervous system to cause severe sort of infectious type diseases such as meningoencephalitis. And then COVID-19 also causes vascular problems, blood clotting, and that can lead to strokes. Now, I've mentioned Clozapine already. I want to expand on it a little bit. So it's a special medication that's used when people with schizophrenia don't get better with other antipsychotic medications. And it requires ongoing blood tests. The first 6 months, weekly, and then reduced frequency after that if the blood counts are stable. And the reason we test the blood is we're looking for the white cell count. The white cell count can, in less than 1% of people who take Clozapine, go to dangerously low levels. There's several considerations here. For instance, especially when there's a lot of coronavirus circulating in the community, we want to reduce the need for people to go to get blood tests, to go to the hospital. So Health Canada has agreed that even though the blood tests are required, in certain cases, we can reduce the frequency of the blood tests if somebody's blood counts have been quite stable for a while, for instance. So we're doing that with some of our patients. But another thing to mention about clozapine is that when people get an acute infection like pneumonia or even a urinary tract infection or presumably COVID-19, that changes the metabolism of the medication and makes the blood levels go higher, and they can become toxic. And this can lead to things like sedation, in severe cases, seizures. And this too has been associated with increased risk of pneumonia. So it's just something to be aware of. About 30% of people with schizophrenia could end up taking clozapine, although in BC, it doesn't seem like we've reached that degree of treatment such that we have 30% of all patients on clozapine. Although it could be a goal that we should work toward, though, because it is the most effective treatment for about that proportion of people. Now, something else I should mention is the service impacts on our mental health and hospital programs because of COVID-19. Back in the spring, and we're poised to do it again with the second wave, we had to reorganize our inpatient services such that we created a COVID ward for people who needed acute psychiatric hospitalization. So anyone who was admitted to psychiatry and tested positive would go to that ward to avoid, obviously, transmission to other patients who were not infected yet with COVID. Healthcare staffing has been affected. Obviously, if somebody gets exposed or infected with COVID, that workers or doctor is going to be out of service for a number of weeks. But also because of the demands on our hospitals and clinics from testing, from increased volumes of patients, contact tracing, we've lost some of our staff on psychiatry and in the mental health teams. Not a huge number yet, but we do have contingency plans in place in case the impacts grow. Harm reduction services. Now, we know that COVID is the most recent public health emergency in BC. The other one that we were dealing with even before and continue to deal with is the overdose crisis. Because of requirements for social distancing and other service impacts, harm reduction services had to be reduced initially back in the spring, but we've been working to make sure that those reductions are reversed. And there are other measures that have been enacted to try to increase the availability of like opioid agonist therapy, OAT. This is treatments like methadone, Suboxone, etc. And this is an effort that we're making to try to improve access for those, and also for safe injection or consumption sites, etc. You may have heard in the news recently that a new overdose prevention site is going to be opening in Vancouver. Our staff obviously have to protect themselves, so they will be wearing PPE whenever they see clients in person. They also have been using televisits, technology, even telephone to visit or evaluate clients. But if someone needs to be seen in person, then they should be seen in person, and the staff should wear PPE. ECT had been reduced in availability back in the spring, but that was brought back to previous service levels over the recent months. And then medication injections, I should mention. I don't think any patients are missing those, but we see it as a very important and essential service, but at the same time, with the social distancing and with service impacts, there's the possibility of patients falling through the cracks. So family members, can help the clients and the case managers stay on top of that and bridge a gap if necessary to ensure that nobody misses their doses. So that covers everything that I wanted to talk about. And I can't take your questions directly, but I hope that it was informative. And if you have a really burning question, you might be able to funnel it through the BC Schizophrenia Society. And perhaps I could get back to some of you that way.